Want to welcome everybody to Rush University Medical Center Division of Nephrology Renal Biopsy Conference for March 10th, 2022. My name is Roger Rodby, and I want to start by welcoming everybody new, and wishing everybody a very happy World Kidney Day. This is very big, and we need something good with everything else that's going on. So very unfortunate. We just get looks like COVID's going away, and we have another international disaster. But politics aside, we've got a great case today by Dr. Gashti. As usual, the case has been identified with names, dates, etc. Today's CME activity code is 485024. If you aren't subscribed to our YouTube channel, please do. All of these conferences are recorded and they're put up on our YouTube channel, so please subscribe. And if you want to get on our mailing list, and just let us know, we would love to add you. Tell your friends. Everyone will be muted except the faculty. Put all your comments in the chat box and we'll try to get to them as best we can. Let's get started with the case. Pull it up. I think, Dr. Gashti, are you reading it?
I am. So our patient is a 68-year-old Hispanic male from Mexico who has a history of hypertension. He's taken valsartan hydrochlorothiazide and amlodipine. He's also diabetic and takes metformin. Both of them were diagnosed simultaneously about 7 years prior to the current admission. He also has hyperlipidemia, and he basically comes to the emergency room because he's been having headaches and he feels that his abdomen is distended and he's experiencing leg swelling. He reports that he started having headaches about 6 months prior to the admission and started taking ibuprofen about 4 to 5 times per day. Over the course of the past month, he started to have abdominal distension, and for the past week, he started to have leg swelling and decreasing urine output, so he came to the emergency room. His labs in the ER showed his BUN and creatinine were elevated to 86 and 4.0 milligrams per deciliter. His last known baseline serum creatinine from a year prior was about 0.7 milligrams per deciliter. He was admitted for AKI. He remained oliguric for a while and his creatinine continued to rise. So he was actually started on dialysis on the 3rd day of hospitalization as his BUN reached 130 in anticipation of needing to do a kidney biopsy. So his past medical and surgical history is significant for hypertension, diabetes, hyperlipidemia. He's a non-smoker, doesn't drink or do any drugs. He doesn't have any family history of kidney disease. He has no allergies. His medications, as I mentioned, were valsartan, hydrochlorothiazide, amlodipine, metformin, and Lipitor, atorvastatin, 40 milligrams. His review system was significant for headaches, visual disturbances, abdominal distension, and low extremity edema. On exam, he was afebrile. So he had a blood pressure of 150/90, heart rate of 90, respiratory rate of 20. He weighs 200 pounds, 91 kilos with a BMI of 28. In general, he seemed pretty in no acute distress. He was Spanish speaking. His lungs were clear. His cardiac exam was unremarkable. The pertinent parts of the exam were abdominal distension and lower extremities, which had significant pitting edema. And his neuro exam was grossly unremarkable. His labs, his sodium 135, potassium of 4.6, chloride of 104, CO2 of 16, BUN and creatinine of 80 and 4. His glucose was 175, total protein of 6.3, albumin of 2.7, calcium of 9.3, T-Billy 0.4, alk phos of 80, AST and ALT were normal. His white count was 9, hemoglobin of 13 with a platelet count of 375. His differential on the white blood cell count was about 70% neutrophils, 22% lymphocytes, 5% monocytes, and 2% EOS. His total cholesterol was 350 with triglycerides of 221, HDL of 54, and LDL of 252. His SED rate was elevated at 60. The rest of his immunologic workup, which included ANA, double-stranded DNA, ANCA, complements, PLA2R, viral serologies, including HIV, Hep B, Hep C, COVID, were all negative or normal. His SPEP had no monoclonal spike. His kappa level was 10.6, lambda of 5.1 with a kappa lambda ratio of 2.0. His urinalysis was light yellow urine, turbid color, specific gravity of 1021 with a pH of 6, 4+ protein, 2+ glucose, negative for ketones or bilirubin, 1+ blood, 10 WBCs, 5 RBCs, and 1 Highland cast. His urine protein level was 1838, urine creatinine of 86 with a ratio of 21 grams per gram. His urine protein electrophoresis with immunofixation, no monoclonal spike, and 75% albumin. His renal ultrasound showed kidneys at 12.8 and 12.5 centimeters, increased renal cortical echogenicity, trace perihepatic free fluid, and trace right pleural effusion. So a percutaneous renal biopsy was performed.
Great, thank you. Nice protocol, concise. Anybody have any questions for Dr. Gashty?
Yeah, did he ever have, you may have already said this, did he ever have any microalbuminuria checked in the past and any evidence or any history of retinopathy?
So he does not have retinopathy, and he did have a urinalysis 2 years ago, and there was no proteinuria on that. They didn't have a quantification, just a dipstick did not have proteinuria.
And do we have any better idea what these headaches were about, and was he scanned or anything?
He had a regular CT without contrast that was unremarkable. His primary physician had diagnosed him with sort of tension headaches and encouraged NSAID use.
Encouraged NSAID use?
Yeah. He said just
he took his doctor's advice.
This was, well, he's been taking it and for a few months, and his doctor basically said, just keep doing what you're doing. They couldn't really, based on CT, they couldn't find anything. So he hasn't been referred to a neurologist.
Yeah.
COVID vaccine status, fully vaccinated, plus a booster.
And was it recent vaccine?
His last dose was probably 3 months prior to when he came in.
Okay. All right. We're going to start with a poll. We'll do this a little different today. We're going to start with a poll and see what people think before we discuss it. So what do you think the path will show? We have 5 choices here: minimal change disease, focal segmental glomerular sclerosis, collapsing glomerulopathy, crescentic IgA nephropathy, or membranous glomerulonephritis. All right, so about 31% said minimal change disease, 16% said focal segmental glomerular sclerosis, 19% said collapsing GN. Only one person. It's kind of funny because while this was being while Dr. Gashty was presenting the case, I said I texted Dr. Baxi, throw in crescentic IgA in there real quickly, thinking I'd get some bites, but apparently didn't get many bites. And membranous GN got 31%. So it's kind of all over the board, which is, what we like to see, because we like to justify our renal biopsies. With that in mind, Dr. Corbett, you want to walk us through your thoughts on this case, please? Unmute yourself.
It's obvious I have to unmute myself. Before I said, never mind. I said the case is fairly obvious. I think it's straightforward. This guy has NSAID-associated minimal change disease until proven otherwise. I'm assuming he was taking the NSAIDs all the way up until the time he came in, right, Casey?
Yes.
Yeah, so there was no hiatus between the biopsy. I mean, it's not as if he had stopped them a week or two before. So I think, the E on the eye chart here is pretty obvious to see, and that is the NSAIDs. And nephrotic syndrome, acute renal failure, I mean, that goes hand in hand. The acute renal failure is usually a lymphocytic interstitial nephritis, not associated with eosinophilia. I know his eosinophil count was 2%, but I don't know that his absolute eosinophils were actually high, and 2% is not that high anyway. He did have some white cells in the urine, which again could go along with this. And I think, all the serologic evaluation was negative. And as Casey had said, in the relatively recent past, urinalysis, he had no protein. So, the issue of diabetic nephropathy, I think, has to be low on the list here as a cause for nephrotic syndrome and renal insufficiency. I mean, I guess it's always possible he has some background diabetic renal disease, and he could have some ATN because he was taking NSAIDs and was on an ARB as well. So I guess, that's always a possibility that we see background diabetes and ATN on that. But on top of that, but I can't blame, I doubt, this is a sudden onset in his nephrotic syndrome. And I think the NSAIDs just fit nicely. Could it be collapsing FSGS? Sure. I mean, that's always a possibility. It could be FSGS with a tip lesion and ATN for that matter from the NSAIDs. And his kappa lambda ratio is a little elevated at 2.08, but with this level of renal function, the ratio goes up to 3 to be normal. The ratio goes up to around 3. So I don't think there's anything paraprotein associated here. Membranous, I mean, that's always a possibility too with ATN, or a crescentic membranous, if you will. He did have some microscopic hematuria, but it just, for me, there are a lot of possibilities. I just think that high on the list has to be NSAIDs associated minimal change disease with ATN, and we'll get the biopsy and see what else pans out. I mean, serologically, there's just nothing else that I can put my finger on. And the only other thing in the history that I've already said is the diabetes. And I think at best there may be background diabetic changes, but I can't attribute all these things to diabetic nephropathy.
So I know you've talked about this a lot with non-steroidal induced, that it's predominantly lymphocytic, but I think there are situations where you can have eosinophils, and I don't think it's as straightforward as you're saying.
Well, let me put it this way: nothing's ever 100%, but in general, the teaching is that these patients don't come in with rashes, eosinophiliuria, and a fever, kind of the classic presentation that we see with things like penicillin or sulfas or cephalosporins. So can they occasionally, can some of them have eosinophils associated, I guess, with interstitial nephritis? I think we've seen cases of that. I just think that, in general, the rule of thumb is that they don't, but, there's always an exception.
Yeah, actually, I'm sorry, I should have been clear. What I was implying is not a systemic reaction like sulfas or penicillins or whatever, but in the kidney to see eosinophils, and I don't know that it isn't a pure lymphocytic infiltrate often. But you're right. I mean, it's not typically a systemic kind of penicillin rash, fever, etc. So, Dr. Glassick, Dr. Corbett said this is an obvious case of non-steroidal induced minimal change disease. It's our role to generate a differential diagnosis. And so what else do you got for us?
Well, I'd have to agree with Steve in this case. Everything seems to point in the direction of non-steroidal anti-inflammatory agent-induced disease. This would be a very rapid course for membranous, with a serum creatinine going from 0.7 to 4 in a year, which would downgrade membranous. The quantity of proteinuria is interesting. This is one of the examples that is frequently cited for showing massive proteinuria. However, I don't usually attribute much clinical significance to the magnitude of proteinuria over nephrotic ranges, but 21 grams per day is exceptionally high, even for membranous. So I would go along with Steve on this case.
Dr. Rubin, what do you think?
Well, not much more to add, except for one, I agree with Steve regarding the old teaching that eosinophils are classically lacking in NSAID-induced kidney disease. Number two is I always quote the old studies from Mayo regarding the association between NSAIDs and membranous. I personally have never seen a case, although I read about it in the literature. Number three is, I think Steve mentioned it, but again, focal sclerosis is a consideration. Number four was mentioned in the chat. ALECT2 amyloidosis is also a consideration, although as stated, even though it's usually two interstitial cases of glomerular involvement have been described as well.
So you want to expand on that a little bit?
Well, it's a form of amyloidosis, which is preferentially seen in individuals of Hispanic Mexican ancestry. We see quite a bit in the southern portion of the US, here in Texas. Classically, it's associated with tubulointerstitial involvement and thus tubular proteinuria, not this degree of glomerular proteinuria, but cases of glomerular involvement by this form of amyloidosis have been described, and that's the extent of it. I mean, it will require laser microdissection with mass spectrometry for proper diagnosis.
Yeah, we see it once in a blue moon, but it's always interstitial, and therefore you certainly wouldn't expect nephrotic syndrome with an interstitial process, and certainly I can't imagine with this degree either
Rod?
proteinuria. Yeah.
I do want to point out 2 laboratory tests that you might want to use as an argument in favor of non-steroidals. That is the elevated C3 and C4. These are values that are at the upper limit of normal, at least for the lab I use in California. And of course, both of these proteins are acute phase reactants. And in non-steroidal disease, as opposed to membranous, there is interstitial inflammation, which would go along with the elevated white blood cell count in the urine. So I think you could add those features as supporting the diagnosis. I don't know their sensitivity and specificity, but I think it's worth remarking.
My fear here is we're all going down the same path, and I got a feeling that we're all going to run into the same dead end. I don't know why I have this lurking sensation that we've been set up.
You have this lurking sensation because that's what often happens, and it's not that we try to set anybody up. It's just that obviously the cases we present here tend not to be the most straightforward because they generate the best discussion. But sometimes a cigar is just a cigar, so we'll have to see.
Yeah, I think we went down the rabbit hole is what happened here.
Well, you started out with this is the most obvious case.
Well, I was doing it just because I always do that, and I'm usually wrong when I do that. But then when everybody else said the same thing, I'm like, oh boy, here we go.
Well, I think
All
if
right, well-
Bill Whittier was here, he would have went 1 through 5 being minimal change disease. So
There you go.
Let's spin the wheel. An extra hard spin today for kidney day. Kelly, is Kelly here today?
Can you hear me? Sorry.
Yep,
Oh,
perfect,
good.
perfect.
Oh, perfect. Yeah.
I will share the screen. Give me a second. I'll give you control. Just remember, there's sometimes a lag with the mouse.
Got it.
Go ahead and click on the screen. Yep. And then you can advance the slides on the left down. Yep.
Here? Okay, perfect.
All right, the pressure's on, Kelly.
I know. Let's see if you're right. Okay. So the first slide we have here is the trichrome stain. We have 1 core, and it appears to be a pretty good sample. I see glomeruli throughout. Here we're looking more for chronicity. So the blue staining material, the more of the blue staining material, the more typically scarring there is. There is definitely some scarring here. I would probably say maybe in the realm of like, I don't know, 30 to like 40, 50% ish. The tubules aren't quite back to back. They're a little bit more spaced out.
Yeah, I think you're too high on that estimate.
Okay.
I mean, I see just some focal areas of scarring and tubular atrophy, Some of the collagen is just, between the tubules, but the tubules don't look kind of atrophic and scarred. Overall, it looks kind of minimal focal, 5–10%, I would estimate.
Okay.
You know what's nice about this view is, it goes from cortex down to medulla from the top to the bottom, because when you get deeper down there, you don't see as many glomeruli, and you can see how it's kind of striated there. So it's a real nice picture of a full core.
Okay, so here we have an H&E stain. So here we're kind of mainly focusing on the tubules, it seems like. So what kind of jumps out to me on this slide is kind of the interstitial infiltrates. It appears to be mostly like lymphocytes. I'm kind of looking for eosinophils here, because on the differential obviously is interstitial nephritis.
Yeah. I don't know if you could pick them out at this lower power. We'll see a higher power, but yeah, that's right. At this medium power, you could see the diffuse interstitial infiltrates between the tubules. So definitely acute interstitial nephritis.
Kelly, would you say it's minimal or moderate or pretty bad?
I would say it's moderate.
Yeah.
Yeah, what's the difference between moderate and pretty bad? I'm sorry, but it's just, when you look, the tubules normally will be right next to each other, and they're really separated. And it's nice that they're not separated by fibrosis; they're separated by cells. But it's pretty bad. David, pretty bad.
Yeah. I would say like a moderate intensity.
Okay. All right, so here's our higher power. Okay, so here what jumps out to me, I think these are EOs, correct? Like the pinkish cytoplasm.
That's right. Yeah, it's called
Okay.
eosinophil because the eosin is a stain, the pink
Yeah.
red stain in the laboratory. So yeah, they stain red. They have the red granules in the cytoplasm.
Okay. Is there anything else? I don't see much else on this slide besides just the infiltrate.
Yeah, the other
Yeah, but
cells are lymphocytes, mononuclear cells, and then right in the center is a tubule, like with active tubulitis. You could see, a lot of nuclei, the lymphocytes kind of actively, attacking the tubule. So there's kind of, acute a component to this.
Kelly, could you just again tell us, especially for Dr. Corbett, what's the name of that cell again?
This would be an eosinophil, Dr. Corbett.
Okay, good. There we go. Thank you.
Yeah, well, he was probably taking a PPI and didn't tell anybody. But there are other cells there too, right? Which you pointed out. I didn't know if there were some plasma cells, but many of them were lymphocytes as well.
Yep.
So it wasn't just a pure eosinophilic interstitial nephritis.
It never is.
It's never pure.
Okay, so now we're moving on to the PAS stain. We obviously have one glomerulus right in the center. Okay, so right here we have the, it looks like the hilum, and maybe, is this the macula densa?
Yeah, at 6 o'clock.
Okay, cool. So here we have the hilum. The capillaries appear open. I don't see any segmental scars for sure. Really, I don't really see any mesangial hypercellularity or expansion. Moving on to the actual tubules, the brush border here appears to be intact. I'm kind of looking around to see if any tubules have lost their brush border. This one kind of looks atrophied, maybe lost of brush border here and over here.
Yes, yeah, those tubules right there are thinned out and have no brush border right at 9 o'clock. Yeah, right.
Right at 9 o'clock.
Yeah, right there. Yeah, see how the
Right here,
epithelium
okay.
thinned out, no brush border. And then the tubule up at 2 o'clock, you can see the epithelium is sloughing off.
Oh, right here.
Yeah,
Okay.
right there. Yeah, so
Okay.
definitely some ATN.
Okay. Okay, we're going back to H&E now. So we have two gloms that we're looking at here. The glom up here, we have the hilum. And then again, I see open capillary loops, maybe some mesangial hypercellularity here, but overall not much. Again, no segmental scars. I don't see any necrotizing or necrosis. Let's see, the one down here, kind of same thing. I open capillary loops. It looks overall pretty healthy to me.
Good.
Yeah.
David, those are just red blood cells?
Yeah, unlysed red cells.
And is that just the way it's processed, or?
Yes, yeah. I mean, the tissue sits in an acid, usually for an hour before processing to lyse all the cells, but sometimes if it doesn't fix long enough, they remain in the H&E stain.
Okay, so here we have the silver stain or the Jones stain. And in this stain, we're kind of looking for any breaks in the basement membrane, any spikes or holes that would indicate presence of like membranous disease. So I don't see any breaks in the basement membrane at all. Kind of following the contour of the loops, I don't see any spikes anywhere. Again, they appear pretty, everything appears pretty healthy to me.
Yep, good.
Okay, so we're going back to PAS stain again. So here we're just looking at several tubules. So I think again, just is demonstrating kind of atrophied tubules, loss of brush border. Here we have.
So Kelly, most of these are acutely injured and instead of atrophied, right? Atrophied would be shriveled, shrunken down, thickened basement membranes, these are acutely injured ATN.
Got it. Okay.
Yeah.
And then here we have our infiltrate up here.
Yep.
Kind of creeping in.
Yeah.
Okay.
Now this is a subtle finding, but in the oh, okay.
Sorry, I think I advanced.
Okay.
Forward. How do I go back?
Okay, but that's okay. We could stay on this slide. What do you notice? Something jumping out to you on this slide?
I mean, there's a lot of like pink. I mean, there's a lot of pink material between the tubules.
Yeah, pink. And what's the intensity of on the PAS stain?
I mean, it's less bright than kind of the than the actual tubules. It's weakly PAS positive.
Yes.
What we go by. Yeah.
Yeah. So there's this amorphous weakly PAS positive material in the interstitium. What does that make you think of?
Makes me think of amyloid.
Okay. So what stain would you like to see?
Like the Congo red.
Okay. All right. I think that's our next slide. Oh, one more H&E in there. Sorry.
Oh, okay.
Yeah. Here it is a little bit more prominent. You could see kind of spacing out the tubules in the middle, this kind of amorphous pink material.
Yeah.
All right. So we got a Congo red stain.
Yeah. Sorry, I'm going forward. All right. So it's positive.
Yeah.
Kind of just again highlighting the amorphous material in between all the tubules.
Yeah, so it's congophilic. It's staining like amyloid. So then we'll look at the under polarized light to see if there's birefringence, which is our next slide.
All right. And then there looks like there is.
You got to click it again.
Oh.
I love it.
Yeah, if you could click back and forth, you could really highlight the birefringence.
Watch, I'll do it, Kelly. Hold on one second.
Okay.
It has to do with the way the Congo red binds into the beta-pleated sheets that form the microfibril. They're 90 degrees to each other. So you can almost see the orientation shifting from one to the other 90 degrees different.
you
Yeah,
go back two
I see
slides?
the question there. Any red, Congo red in the glomeruli? There was
So-
not. This was
well,
just
actually-
interstitial only.
Isn't it, don't I see it there or no?
Those are red cells.
There's my color
Yeah,
blindness.
that's not a glomerulus there.
Well, that's a glomerulus, but it's not down there, right?
No, yeah, there was no amyloid in the
Okay.
glomeruli.
Okay.
Go ahead, Kelly. I'll let you advance the slides now.
Great. Immunofluorescence, IgG negative.
So no background diabetes at least based on that.
And kappa lambda were negative, David?
Yeah.
Okay, so now we are moving on to EM. So just to get oriented here, here we have the capillary space, our basement membrane, and then urinary space out here. And right away I can see just podocyte effacement. They don't look healthy or normal.
Yeah, would you say diffuse or focal?
Based on what I'm seeing here, it looks pretty diffuse.
Yep.
Okay, so here again, we have the endocapillary space, the basement membrane, and the urinary space. And again, diffuse podocyte effacement. There's no deposits within the basement membrane at all.
Yep.
Okay, kind of showing the same thing. So endocapillary space, basement membrane, urinary space, diffuse podocyte effacement. Basement membrane is measuring 427 nanometers, which I believe is normal or within the normal range.
Yep.
Okay, so based on these pathology slides, we have evidence of amyloidosis or amyloid nephropathy, AIN, and minimal change disease with diffuse podocyte effacement.
Yep. And at the time of the report, I said, interstitial amyloid. And we had to send the tissue to Mayo Clinic for amyloid subtyping.
And
Yeah, and it came back as yeah, okay. It came back. I don't want to spill
the suspense is killing me, David.
yeah, yeah. It came back as ALECT2 amyloid.
So it did come back as ALECT2. Well, that was put up early in the chat, and it's not something I sure would have thought about, but good.
But you think
good
this
for
is
the-
just
good for
dumb
the
luck?
team.
You found there was a separate reason for the biopsy that had nothing to do with the amyloid.
Why don't you tell us what you think based on this, Steve?
Well, I think for sure. I mean, I think that this person had, and we'll find out by stopping the NSAIDs and starting steroids to see how quickly he goes into remission. But I think that he had NSAID-associated interstitial nephritis with a few eosinophils and minimal change disease. And I think the biopsy, which made that diagnosis, also kind of tripped along finding this ALECT2. And you wonder how many people, Hispanics, have just subclinical ALECT2 in their kidneys. This gentleman's 68 years old, and just a few months ago, or I forget when the 0.7 was, had pretty normal renal function. So I don't know how, if you were to do an autopsy series, how many people would just have subclinical deposits of ALECT2 that were, not clinically, relevant, I guess, you might say. It's like they say, even a blind squirrel finds an acorn every once in a while. And I think we tripped across this, but that's the way I'll put this together for now. And I'm hoping that by stopping the NSAIDs, and in this case, I would definitely give steroids.
Do you want to elaborate on that? Stop.
This guy's got massive.
Stopping the drug, or just stopping the drug and giving steroids.
I do both. This guy's got massive proteinuria and acute renal failure with interstitial nephritis. So I'd give steroids for sure.
What's the data for that?
Well, he's got interstitial nephritis, and if you know, in patients with interstitial nephritis, no matter what the drug is, the longer you wait to treat it, the more likely they may have irreversible damage.
What about the nephrotic syndrome when stopping
Yeah,
steroids?
that I think is a little, I'm trying to remember your friend Parazella, I think, did a review on drug-induced renal diseases. And I think in there, I remember him, in certain situations, when people have massive proteinuria like this, stopping the drug definitely can lead to, as we've seen and reported, resolution of nephrotic syndrome, usually within a few weeks. But there is the suggestion that if they're this nephrotic, that there might be some benefit by giving steroids to accelerate the remission. So I don't know that there's a lot of good data.
Dr. Rubin, do you have any, or Dr. Glassick, do we really know how prevalent ALECT2 is in this population?
I think Steve has asked the critical question. In over 60-year-old Hispanic individuals, what is the prevalence of asymptomatic ALECT amyloid? And I can't answer that question. I don't know whether that's ever been looked at. But in this case, I would strongly suggest that it's just an incidental finding, not of, perhaps of long-term clinical significance, but over the short term, I don't think it's a very clinically significant observation.
Yeah, the only thing I can think of is that, maybe his proteinuria is a little worse because he's got tubular disease and he obviously has a bad podocytopathy, but maybe it's a little worse because he can't even reabsorb as well because of the amyloid. But who knows?
So I sent a paper to Prabir from Chris Larsen from Arcana, published in KI in 2014, and basically they reviewed 400 cases of amyloidosis and they found 40 of ALECT2, primarily in the population we are describing.
But these were people that probably had a biopsy for an indication, right?
Right.
Yeah. Marco, yeah.
Right. So,
Mario.
yeah, to your question, Steve, much like Dr. Glassick said, I have no information.
Dr. Rubin, have you seen this incidentally show up like this? I mean, you say it's a lot more prevalent in your neck of the woods. Have you seen a case that's kind of biopsy for something else?
In the local biopsy conference, we see on average 4 to 5 cases a year.
Wow.
In some of the instances, it's totally unpredictable, like in this case. In some others, it's a biopsy for cause and you find it.
Roger, I have seen personally a couple of cases of ALECT as an incidental finding in IgA nephropathy biopsies in Hispanics. The test will be whether the patient's serum creatinine returns to normal following discontinuance of the drug and treatment with steroids. And I would bet a couple of bottles of Brazilian beer that it will come back to normal.
A couple bottles of Brazilian beer. Well, that's 2 more bottles than I have, so I'm not going to bet. Casey, you want to tell us what you did?
Yes, really nice discussion because a lot of the things that I was going to highlight was discussed. But Prabir, can I get control of the?
There we go. Give me a second. I'm going to give you control of this. Let's see. Go ahead and click on the screen. Yep.
All right. So these were the diagnoses that were given to us: minimal change disease, acute and chronic interstitial nephritis, ATN, and interstitial amyloid. And we did send the tissue to Mayo for mass spec, and they did come back and tell us that it was a ALECT2 amyloidosis. So I wanted to spend just couple of minutes on the minimal change in interstitial nephritis, and then maybe a few more minutes on the ALECT2. NSAIDs and nephrotic syndrome in general, the most common lesion that we usually think about and see is minimal change disease. And one of the interesting things about it is when you do have minimal changes is you usually have AKI with it. And the pathophysiology of AKI is most commonly ATN and also AIN as well. And as Dr. Corbett mentioned earlier, usually there is no extrarenal manifestation like we see with other drug-induced AINs with fever, rash, eosinophilia, although I was not able to see that the tissue doesn't have eosinophils. There is no peripheral eosinophilia, so I'm not sure why the discordance would be. And the incidence is still very low of NSAID-induced nephrotic syndrome. And the hypothesis is that the decrease in the prostaglandin generation from the NSAIDs leads to increase in conversion of arachidonic acid to leukotriene, and that activates T helper cells, and that by itself can affect the podocytes. So this is something we see quite commonly, and the treatment is pretty straightforward. Stop the drug, and depending on the severity, give steroids. If it's just nephrotic syndrome, stop the drug. Usually within 2 weeks, things can get better. Membranous, as Dr. Glass brought up, was also one of the nephrotic syndromes associated with NSAIDs. Interestingly, when patients present with membranous, they don't have AKI. So that's one of the differentiating factors between the two would be that if you see AKI, it's probably minimal change. If you just see nephrotic syndrome, it could be membranous. But the tissue can actually be stained, and unlike in primary membranous, where IgG4 is predominantly stained, in NSAID-induced membranous is usually an IgG1 deposit. But either way, I think this is very rare. I personally have not seen a case of NSAID-induced membranous disease, but there are reports where they clearly associate the NSAIDs. It goes away when they discontinue the drug, and then with the reintroduction of NSAIDs, the disease comes back. So it's a pretty straightforward association or causation. And the use of it.
I'm really glad you brought that up, because I've always kind of poo-pooed that association because, non-steroidals are pretty ubiquitous. But I think the point that it being a different immunoglobulin, it makes a strong case. And also the story that it seems so temporarily related, you stop it and it goes away. But it's not very common. And like I said, I wasn't even sure that it was a real phenomena, but I think you've convinced me.
Yeah, and it may have to do with the antigen presentation from the NSAID drug that may cross-react and cause the deposition. But in one of the biggest observational studies that looked at the association of NSAIDs and nephrotic syndrome, the odds ratio, so NSAIDs are associated, but actually COX-2 inhibitors were not. There was a non-statistically significant trend, but the conclusion was that a COX-2 inhibitor incidence is very, very much different than NSAID. So I found that to be also interesting. So what about the other part of this? So I did start this patient. We obviously stopped the NSAIDs. I started the patient on prednisone, and I will give you follow-up at the end of the talk about what happened. The patient stayed on dialysis for 2 or 3 weeks, and he did start to improve. And I'll give you the final creatinine and protein level at the end. What about the amyloid part? So as you all know, obviously amyloids are just a ubiquitous group of diverse disorders, abnormal folding of proteins, a whole bunch of different precursor amyloidogenic proteins, like over 36 of them have been identified. Most common are AA and AL amyloidosis, but there are a lot of hereditary forms derived from fibrinogen, apolipoprotein, and so on, and lysosomes that are also amyloidogenic. In fact, this is not meant to be an exam for your eyesight, but this is a table of the 37 plus precursor proteins for amyloid, and they've categorized them into the various, whether they're apolipoproteins or hereditary or other. And here, somewhere in the bowels of this table, is the leukocyte chemotactic factor 2, which is essentially both nephropathic and also hepatopathic amyloid. So that's kind of interesting. This is one of our old fellows, Dr. Raj, with Dr. Whittier, who actually presented a poster at 2017 ASN presenting a case of ALECT2 amyloidosis. This gentleman had a creatinine of 1.8, was essentially unknown etiology, got biopsied, and did have amyloid. And There's really no data on treatment for this, but colchicine, which is used in secondary amyloid from familial Mediterranean fever, does seem to have some anti-chemotactic properties. So this patient actually was started on colchicine. I have no data to back that, and Dr. Whittier is not here to defend himself, but he did tell me that the patient's creatinine is still 1.8, and he has essentially minimal proteinuria 3 years after this biopsy. So for what that's worth, it's interesting that we had this case about 5 years ago. What is this leukocyte chemotactic factor 2? It's essentially a small 133 amino acid protein that's made in the liver. The first case was reported in 2008. We've known about this protein since about 1997. It's not always restricted to the kidney, but most cases are essentially renal limited, but there are definitely cases in liver, adrenal glands, GI, and parathyroid, and other organs that have been reported. As Dr. Rubin correctly mentioned, this is preferentially affects patients of Hispanic ethnicity. In some of the reports, about 90% of the patients who had ALECT2 were of Hispanic ethnicity, mostly Mexican and Mexican Americans, but they have been reported in Punjabi Indians, Egyptians, Native Americans, and Chinese of Han ethnicity. So this is not just in Hispanics. Interestingly, one of the differences between this and other amyloids was that there is a preferential for cortical as opposed to the deeper medullary interstitial involvement. So if you had that one core that had both the medulla and the cortex, that would have been really interesting to see if sort of the amyloid deposition actually stops at the cortical level. The pathogenesis is really not that well understood. We know that this protein is essentially produced by the liver. It has both chemotactic properties, but it has a whole bunch of other cell proliferative, immunomodulatory, carcinogenic effects. The thinking is that there are some polymorphic mutations that are associated with it. There's a polymorphism of a G nucleotide. There's in the ALECT2 gene in the position 172, and it's one of those two-hit hypotheses that they think that maybe you have to have some of these mutations, which could be the first hit, and then you have a second risk phenomenon. And that could be either interactions with some of these regulatory proteins, co-risk factors with hypertension, diabetes, and obesity, and Hispanic origin that could make this an unstable misfolded ALECT2, which leads to the fibrils forming and then depositing. The liver deposition is interesting because many patients do have the ALECT2 deposition in the kidney, but it's not, the deposition of ALECT2 does not equal amyloidosis in general. So unless they've actually formed the fibrils, which some do and some don't, you may or may not have amyloidosis in the liver as well. As also was discussed, it's usually renal predominant, but very interestingly, this is really hard to actually pick up because a lot of these patients have isolated CKD with minimal proteinuria. Only about a third of these patients were nephrotic, and a third of them didn't really have any proteinuria at all. So think about how many 70-year-old Hispanic males that come to your clinic with a creatinine of 1.5 and maybe 500 milligrams of protein who have diabetes and are obese and have hypertension. And I wouldn't even think twice about biopsying them. So some of the other things that don't fit, quote unquote, with diabetic nephropathy may make you think about this, but the fact that there is no treatment currently for this makes me also not want to really biopsy this because what am I going to do about it? But at least knowing this is interesting. One of the interesting things is that it actually has a really good prognosis. If you look at the 10-year prognosis, the top graph A is the graft survival, and the bottom graph is the patient survival. And you can see at 10 years, 70% of these patients still have a functioning graft. And if you compare to some of the other forms of amyloidosis, like apolipoprotein amyloidosis or lysozyme-related amyloidosis, or AFib is not atrial fibrillation here, it's actually fibrinogen alpha chain amyloidosis. Some of these have very, very different prognoses. And ALECT2, essentially, patient survival at 10 years is close to 90%. So this is as most people correctly mentioned, this was an incidental finding. I find it to be interesting, but there's really not much that we need to do, nor can we do about it. So here's a follow. Yeah.
I doubt you could break it down this much, but I wonder about that third, the third with glomerular involvement. I wonder if they have a worse prognosis than the ones that just have predominantly interstitial disease.
I haven't seen that kind of that breakdown. I mean, this is an mostly predominantly. I mean, Dr. Rubin sent an article about ALECT2 having some glomerular involvement too, and that has been reported. But predominantly, this is a cortical interstitial amyloid.
Yeah, but your slide
yeah.
before this had 22 to 33% or something nephrotic, which is really, I never in wildest dreams would have predicted that based on the way I categorize this disease.
Well, the problem with this is that usually you end up biopsying these people who have diabetes and hypertension and are obese, and how much of this is truly the amyloid and how much of this is some of these comorbid conditions is probably not well teased out.
That's a really, really good point.
And so our patient got 6-year prednisone, remained on dialysis for 3 weeks, started to recover function. As you can see, the creatinine as of last check, which was a few days ago, is down to 1.2. Protein creatinine ratio is down to 1.4 gram. And so he's done really well with it. And I kind of really wanted to see what this amyloid looked like while the minimal change in the interstitial nephritis and the ATN is sort of lifted. And I still probably am not at that point. I think that the proteinuria is probably going to improve even more. And hopefully the creatinine will come down even more than this. But that's kind of the follow-up. So the patient's actually done quite well.
We didn't really see a lot of diabetic changes.
No, there wasn't even any basement membrane thickening that much. No.
Yeah. Kelly said that was normal, the 400 or whatever. David, what is the upper limit? Those look pretty big to me. What's the upper limit of normal, Dave?
300 to 500.
Oh, really? Can get that big? Okay, yeah. So I kind of looked at that and thought, well, there's a little bit of diabetic change there, but there really wasn't. So, well, that's really a really great case. And as I put in the chat box, our audience has acted brilliantly again, and it's hard to pull anything past them, but that's a big surprise. And it may be a incidental finding, but it's still very interesting and brought up a great discussion. There was a question somebody said about treatment. There is no treatment for the ALECT2, is there, Casey?
There is no specific treatment. As I mentioned, Dr. Whittier has an N of 1 who gave colchicine to, and the creatinine is stable, but I think the creatinine would have probably been stable without colchicine. So I don't really know what that's doing, but there's this data on other types of amyloid, or at least the MFM type of amyloid, and the hypothesized anti-chemotactic type of properties of colchicine, but I don't know if that's a disease that's a relatively benign disease with a good graft prognosis at 10 years. I'm not sure if giving colchicine is changing anything.
Or is it even warranted?
Warranted, right.
Yeah, so, and I think you brought up the likelihood of minimal change with non-steroidals being somewhat class related. It is less common with ibuprofen, right? Or is ibuprofen in the high risk group?
I don't know if I don't know that to be true. I think that it's both both classes, both all the categories of NSAIDs can cause this. I don't think there is a differentiation. Unless
it's totally idiosyncratic. There's no way to predict it. I mean, it could come after a few doses. It can come after a lot of doses, from what I remember when I reviewed this a long time ago. And as you were talking about, Celebrex, the COX-2 inhibitors can do it too. It may not be as frequent, but it can still happen. And the situation where it came up, we talked about this once before, is the topical NSAIDs. And, there are a few cases of people who have had topical NSAIDs and absorbed enough that they develop nephrotic syndrome, but there's not very many.
Roger, I think it's very important to stress what Steve just said. This is an idiosyncratic reaction. This is not a toxic reaction. We don't know what it predisposes these patients to develop this, but once they have developed it, I would never allow them to be exposed to the same drug again. You have to presume that it would happen twice. And I have seen it once in my experience, that a patient who developed exactly what this patient had, and then 6 months later went back on the same drug and had the same syndrome represent.
And this is a red letter day for me. I think 2 or 3 times now, Dr. Glassick's agreed with me. It's like made my week now. It's kind of like when Ed would agree with me, made my week, but when he would disagree or make it sound like it was wrong, I'd walk around, you know, like for a week going, oh, Jesus, I failed. So what a great day.
Well, it's World Kidney Day, so it was made for you, Steve. So Dick, is this a class effect? Would you say no nonsteroidals or only not the same nonsteroidal?
I think it's a class effect. I would tell the patient specific drugs to avoid in the future and give him a list to carry around in his pocket so that doctors seeing him subsequently don't inadvertently prescribe him a potentially hazardous drug.
Roger, the study that the C. Jason study from 2019, they did actually break it up into the acetic acid derivatives, which is endomethacin, ketorolac, and diclofenac, and then the propionic acid derivatives, naproxen, ibuprofen, and ketoprofen, and there was no difference in the incidence. So it seems to be in both.
Great, thanks. I knew there was 2 basic subsets of nonsteroidals, but I wasn't sure if it was more related. So it really does imply it's probably class and fairly idiosyncratic. Well, that's really great. What a great discussion, Casey. What a great read, Kelly. Thanks, everybody. We'll be back next week. Happy World Kidney Day, and have a safe week. Thank you.